did they view? When did they chart? The data shows who played what part. Was a note changed? Was an alert displayed? The audit trail knows, while memories can fade. So whether you're a lawyer, nurse, or sleuth, pull up a seat, we'll search for the truth. Every click leaves a clue in the fray. This is what the chart won't say.
Hi everyone, welcome back to What the Chart Won't Say. I'm Syra Pasha. I am an attorney who works as an EMR audit trail expert. If you're new to my channel, I recommend that you go back and you start with episode 1. That way you'll learn a little bit more about who I am and what I do, and this episode might make a little bit more sense. So today's episode is about a real case that I worked on, a real lawsuit, and it's especially interesting because the audit trail told a very different story than what the medical records said and what 3 clinicians testified happened to the patient. This case involves a woman who came to the hospital with sudden alarming neurologic symptoms, and doctors suspected a stroke, and that diagnosis was later confirmed. On her second night in the hospital, she was given Dilaudid, which is a powerful opioid pain medication. Within a few hours of that, she became unresponsive, she stopped breathing, and later that day, she was declared brain dead. After I go over the medical chronology, I'm going to summarize what plaintiff's allegations were against the nurse, the nurse practitioner, and the attending neurologist. I'm going to summarize what those 3 individuals said at their depositions in defense of their care. Then I'm going to go over what my client hired me to do. What were the major questions that they wanted answered from the EMR audit trail, and then I'll go over my findings and what I ultimately included in my report. And I just want to emphasize that this video is about learning what you can glean from an EMR audit trail, but it's not meant to be a tutorial for how to analyze EMR audit trails. That is available in my book. So if you're watching this and you are a clinician yourself and you're wanting to learn to do this on your own, I do have a book that's available. After I go over the medical chronology, I'll summarize what plaintiff's allegations were against the 3 clinicians, and then I'll summarize what the 3 clinicians said at their depositions in response to those allegations made against them. After that, I'll go over the main questions that my client wanted me to answer using the EMR audit trail, and what my findings were, and ultimately what I included in my expert report towards the end. And I just want to remind you that these videos that I make are not to show you how to analyze an EMR audit trail. They're more to show you what types of information you can get from an EMR audit trail. And if you are working in the same field that I am, maybe you're a clinician, maybe you're an attorney who does medical malpractice, either plaintiff or defense, and you want to learn how to analyze EMR audit trails like I do have a book that's available for purchase on my website. But this video is not a tutorial on audit trails. A couple other things before we get started. I just want to point out that if you're a clinician watching this video, you're probably going to have a lot of questions about the medicine that perhaps my chronology did not cover. Just trust that both sides in this case had experienced, capable attorneys working for them. Both sides had medical experts review the records for both standard of care and causation. So I know inside you might have a lot of questions, but trust me that people on both sides were working up the case to advocate best for their client. And the chronology that I provide and the information that I provide is what I feel is important enough to understand the work that I did in the case. So it's not meant to be a complete chronology. And if the words that I use, like standard of care and causation, are confusing to you, I recommend that you go back and you watch episode 2, which is the life cycle of a medical malpractice claim. I go over those terms and a lot of other commonly used terms in medical malpractice cases in that video. Okay, I think I covered all the basic background stuff, so let's begin. Real quick while I have your attention, please like this video and leave a comment, subscribe. If you like this kind of content and you want me making more of it, I do need some kind of feedback. These videos take me so long to make, so long. And I don't mind making them if other people are enjoying them, but at some point I need to make a decision about whether the juice is worth the squeeze. So every like, every comment helps me to know that these videos are wanted and appreciated and I should continue making them. Okay, now to the MedChron.
A woman went to her chiropractor for a neck adjustment. During the adjustment, she suddenly developed vertigo, along with a headache. Vertigo is a sensation of spinning or severe dizziness that can make it difficult to stand or walk. In this case, the vertigo was so severe that she was unable to walk. She was taken to a nearby emergency room, where she was diagnosed with a vertebral artery dissection. This occurs when there is a tear in the inner lining of an artery in the neck that supplies blood to the brain, allowing blood to enter the vessel wall and restrict normal blood flow. Because this can lead to stroke, the patient was airlifted to another hospital for a higher level of care. At the second hospital, the patient was admitted to an intermediate care unit. She was evaluated by a neurohospitalist. A neurologist is a physician who specializes in diseases of the brain and nervous system, and a neurohospitalist is a neurologist who focuses on caring for hospitalized patients with acute neurologic conditions. This physician served as the patient's attending. An acute stroke assessment was performed. The patient was documented as having new-onset atrial fibrillation, an abnormal heart rhythm that increases the risk of stroke. A CT angiogram later that afternoon confirmed the vertebral artery dissection, a mechanical cause of stroke. That evening, an MRI of the brain revealed an acute or subacute ischemic infarct in the left cerebellar hemisphere, meaning part of the cerebellum had been damaged due to reduced blood flow. The MRI resulted around 8 p.m. The attending neurologist did not complete his history and physical or H&P note before leaving for the day. There was an H&P in the record timed for about 5 p.m., but it was not signed until the following morning. An H&P is a foundational medical note used to document the patient's condition and guide ongoing care. Overnight, the patient was managed by a nurse practitioner. A nurse practitioner is an advanced practice clinician who can evaluate patients, write orders, and prescribe medications, but typically practices in collaboration with physicians. The patient also had bedside nurses and technicians performing assessments, carrying out orders, and monitoring vital signs. The next morning at around 8 a.m., the attending neurologist re-examined the patient and signed the H&P note. Although it was signed that morning, the note was timed for 5 p.m. the prior day and read as though it had been written before the MRI results were available. For example, it referred to ordering an MRI and waiting for the results, even though the MRI had already been completed. The note included the instruction, "Stat CT head for any worsening or decline." This was not the typical kind of stroke most people think of. Instead of affecting speech or arm strength, this stroke involved the posterior circulation, which supplies the cerebellum and brainstem. These areas control balance, coordination, eye movements, breathing, and heart regulation. The stroke was caused by a vertebral artery dissection, likely related to the earlier neck manipulation. These strokes can appear mild at first, with symptoms like vertigo, nausea, and unsteadiness, but they are especially dangerous because the back of the skull has very little extra space. Even small amounts of swelling can compress the brainstem and cause sudden collapse. The plan emphasized regular neurologic checks and repeat imaging for any change. A STAT CT scan in this setting is used to quickly identify swelling, bleeding, or hydrocephalus before it becomes life-threatening. The attending ordered neurologic assessments every 4 hours. A neurologic assessment evaluates mental status and neurologic function, including alertness, speech, pupil response, strength, and coordination. The goal is to detect early signs of neurologic decline. For timeline purposes, we are going to fast forward to about 5 p.m. later that day. The patient was documented as having severe headache and pain throughout the day and evening, described as persistent and not improving. Shortly before 6 p.m., the bedside nurse administered tramadol after the patient reported headache pain rated 8 out of 10. About an hour later, the pain score was documented as 7 out of 10. Around 6 p.m., the nurse practitioner who had been responsible overnight was back on shift. The medical records indicate neurologic assessments were performed at approximately 6:30 p.m. and 7 p.m., with additional nursing assessments documented around 9 p.m. Between about 9 and 9:30 p.m., the patient complained of 10 out of 10 pain. At 9:57 p.m., the nurse practitioner entered an order for 0.4 milligrams of intravenous Dilaudid. Dilaudid is a powerful opioid pain medication that can cause sedation. The nurse documented administering the medication at 10:03 p.m. and 15 minutes later recorded that the patient's pain had improved to 4 out of 10. The medical records show neurologic assessments documented at 11 showers p.m. However, the records also state that the patient was sleeping at that same time. Both cannot be true, since a neurologic exam requires the patient to be awake. We will return to this later. Neurologic checks are especially important after giving a sedating medication because sedation can mask early signs of neurologic deterioration. According to the documented 11 p.m. assessments, the patient was stable. The records also indicate the nurse checked on the patient at midnight. At that time, documentation shows the patient was resting in bed with a family member present and had stable vital signs. At approximately 1 a.m., the patient's family member alerted staff that the patient could no longer speak or respond and could only squeeze hands. A code blue was called. The patient required intubation and was transferred to the ICU. A CT scan showed an evolving stroke with significant swelling, or edema, and hydrocephalus, a buildup of fluid in the brain. She was taken emergently to the operating room for a decompressive craniectomy, a procedure in which part of the skull is removed to relieve pressure on the brain. The patient never regained consciousness. She was declared brain dead later that afternoon, and her family withdrew care.
That was a brief overview of the facts based on the medical records alone. After the patient died, her husband retained an attorney who ordered the patient's medical records and had them reviewed by medical experts in standard of care and causation. After that, a lawsuit was filed, and the following snippet is going to be a summary of what those allegations were.
Plaintiff's allegations. Against the attending neurologist, the allegations were failure to provide clear and explicit instructions to nurses about when to escalate the case to a physician, failure to take appropriate steps to ensure that worsening symptoms would be recognized, failure to ensure that proper follow-up monitoring and imaging were performed to timely diagnose life-threatening edema before it became fatal. The plaintiff raised numerous allegations regarding the nurse practitioner's care in this case. For purposes of this video, we are not going to cover every one of them. Instead, we will focus on 5 representative allegations that capture the core of the plaintiff's theory and help explain how the events unfolded. Failure to perform a bedside assessment before ordering Dilaudid. Failure to consult a physician in a complex neurologic situation. Failure to recognize that escalating narcotics could mask neurologic decline. Failure to appreciate worsening pain as a sign of developing cerebellar edema. Failure to ensure timely imaging and neurologist involvement. Against the nurse, the allegations were failure to perform adequate neurologic assessments in a high-risk stroke patient, failure to recognize the signs and symptoms of developing cerebellar edema, failure to escalate the patient's condition to a physician despite concerning clinical changes, failure to appreciate that inadequate assessment and escalation increased the risk of injury and death in a patient with this type of neurologic condition, The plaintiff also raised a separate allegation concerning the accuracy and timing of nursing documentation. That allegation will be addressed later, after reviewing what the audit trail showed. Against both the nurse practitioner and the nurse, the allegations were failure to consult with a physician regarding the patient's care despite the complexity of the patient's neurologic condition, including during day 2 of the hospitalization. Failure to consult a physician in connection with the decision to administer Dilaudid in a high-risk neurologic patient. Failure to provide adequate follow-up monitoring of the patient's neurologic status after administration of Dilaudid. Causation. Plaintiff contends that the patient received increasing doses of Dilaudid and other pain medications, which masked signs of neurological decline and delayed recognition of worsening cerebellar edema. Plaintiff further alleges that timely medical and neurosurgical intervention would likely have changed the outcome. According to plaintiff, earlier escalation of care could have led to interventions such as hypertonic osmolar therapy and prophylactic suboccipital decompression, which would likely have saved the patient's life and resulted in a normal or near normal functional outcome. Plaintiff also alleges that the patient's risk of cerebellar edema was not timely documented or communicated. Plaintiff contends that clear communication of this risk and the need to escalate care through physician consultation, ICU transfer, and repeat imaging was critical. Finally, plaintiff asserts that the nursing team did not escalate the case appropriately when the patient worsened, instead escalating care to a nurse practitioner rather than a physician, contributing to the failure to intervene before the patient's catastrophic deterioration.
Now that we've gone over plaintiff's allegations, the next step is to see how those clinicians responded when questioned about those issues at their depositions. And what you're about to see are little 90-second summaries, high-level summaries of how they responded to those questions at their depositions. It's not meant to be verbatim, they're paraphrased, and it's very high level, but it was done in good faith to show you what their positions were. And I used AI avatars to make the next section just for narrative purposes and just to help illustrate what their positions were. They're not meant to represent anybody who was actually in this case. They're just for storytelling purposes.
I do have some independent recollection of this patient, even though it was several years ago. I remember being involved early after her transfer, when she came in with symptoms concerning for stroke and a known vertebral artery dissection. As the attending neurologist, my role was to evaluate her, review imaging, and establish a plan focused on close monitoring and preventing complications. That plan included frequent neurologic assessments and clear instructions to escalate care to a physician and obtain urgent imaging if there were any signs of worsening or decline. I ordered ongoing monitoring because that is how worsening symptoms are identified in this type of stroke. Based on her condition at the time, I did not believe additional imaging was required unless her neurologic status changed. With respect to my documentation, the times listed on my stroke assessment and my second-day progress note reflect when I created those entries. The stroke assessment form was timed for 1:40 p.m., and that's when I completed it. My progress note for day 2 was timed for 4:00 p.m. that afternoon, and that's when I created that note, although I didn't sign it until the next day. While I may not always complete documentation immediately, the content and timing of those notes represent my clinical judgment and the plan that was in place at the time. I was available to the care team after hours and relied on nurses and advanced practice providers to communicate any changes promptly. Based on what I knew and the information I received, I believe the monitoring plan, escalation instructions, and overall care were appropriate.
I don't have an independent memory of this specific patient, so I rely on the medical record and my usual practice to explain my care. I was the on-call nurse practitioner, covering patients during that shift, and I was contacted by nursing staff about the patient's severe headache that was not improving with earlier pain medications. Before making any treatment decision, I reviewed the patient's chart including all available physician notes, nursing assessments, laboratory results, and the patient's medications that were present in the EMR at that time. Based on what I reviewed and what was communicated to me, there were no reports of new neurologic deficits or signs of acute neurologic decline. I don't remember exactly how long I spent reviewing the patient's chart, but I did review everything that was available to me. Whether that took 15 minutes or 20 minutes, I don't remember. I took as long as was necessary to complete my review. The patient had already undergone imaging earlier in the day, and nothing I saw in the chart suggested an immediate need for repeat imaging or escalation to a physician. Given the severity of the reported pain and the lack of response to other medications, I made the clinical decision to order a low dose of intravenous Dilaudid. I relied on the bedside nurse to continue close neurologic monitoring and to let me know if there were any changes. Based on the information available to me at the time, I believe my assessment and decision-making were appropriate.
I do have a vague memory of this patient, especially because it was the first time I'd ever experienced a code blue. That said, much of what I rely on is my charting and the medical record, which reflects how I practice and what I did during the shift. The patient was in significant pain throughout the evening, and managing that pain was a major focus of my care. I performed neurologic assessments as ordered and monitored her closely for changes in mental status or vital signs. The times listed in the chart for those neurologic assessments reflect when I actually performed them. When the patient's pain worsened and was not improving, I contacted the on-call nurse practitioner to report the situation and request additional pain control. At that time, I did not observe signs of acute neurologic decline that I believe required calling a physician instead. With respect to the 11 p.m. entries, the neurologic assessment and the documentation that the patient was sleeping were not inconsistent from my perspective. My understanding was that the patient could be resting or dozing, but still responsive enough to complete a neurologic check. With respect to the midnight assessment, I do not have an independent recollection of that event, so I rely on what I charted. My general practice is to chart assessments either in the patient's room or immediately afterward, within a few minutes of performing them, and I have no reason to believe my documented assessments were delayed or inaccurate. Until the sudden deterioration, I did not observe changes that I believed required escalation beyond the nurse practitioner. Once the patient's condition abruptly changed, I immediately sought help and a code was called. I believe the assessments I performed and my documentation complied with the standard of care.
Allegations were and what the clinician said in response to those allegations generally. Now we're going to go over my involvement in the case. And as in most cases that I work on, I was asked to do a basic check for medical record integrity. And what that means is basically make sure that all of the documentation that was created for the patient has been produced. And that includes maybe draft versions of notes, deleted notes, and also to construct a very tight, objective timeline of care based on the data. And I do that in a lot of cases. But in this case, my client also had 4 very specific questions that they wanted answered. They wanted me to answer using the audit trail data. And if you're a clinician, maybe pause this video and think, what kinds of information or what questions do you have that maybe the data can help you answer? So take a second to pause and then come back to this video. Maybe give yourself a little quiz or just test yourself out to see if you came up with some of the same questions. Okay, so now I'm going to go ahead and play those questions now.
Audit trail questions. First, when were the words stat CT for any worsening or decline added to the neurologist's note, and who viewed that note before the patient coded? This analysis matters because that instruction defines when urgent imaging should occur in a high-risk stroke patient. Whether it existed in the chart before the patient deteriorated, and whether anyone saw it, directly affects whether escalation could have happened in real time. Second, what did the nurse practitioner view in the patient's chart before ordering Dilaudid? This analysis matters because Dilaudid can sedate a stroke patient and mask early neurologic decline. Understanding what information was actually reviewed before the medication was ordered helps evaluate whether that risk was considered at the time. Third, when were the nurses' documented neurologic assessments actually created in the EMR? This analysis matters because neurologic checks are how stroke patients are monitored for deterioration. Knowing when those entries were actually created could go to whether they reflect real-time assessments or potentially documentation created in response to the adverse event. And fourth, is there any additional information that can explain why record shows a neurologic assessment was performed at the same time the patient was documented as sleeping? This analysis matters because a neurologic exam cannot be performed on a sleeping patient. Resolving that inconsistency is critical to understanding whether meaningful monitoring occurred at a point when intervention may still have been possible.
So to answer those questions and to come up with the data that I needed to construct a timeline of care, I needed the audit trail, but I also needed additional audit data from the EMR system that was not in the audit trail. So there's two parts to this. And if you recall from episode 3 or from your own experience, what is an audit trail? If you don't know what an audit trail is and you're still watching this video, I'm impressed, but I encourage you to watch episode 3, which is all about audit trails and what they are. So just as a refresher, an audit trail is a timestamp report generated from the EMR system that shows all auditable actions performed by all users in a patient's chart. And what those actions are like, view, edit, modify, print, sign, etc. And so an audit trail for this patient would show me certain actions performed by the nurse, but it won't show me the content of those actions. So let's use a more concrete example so you can follow along more easily. Let's say the printed medical records show assessments timed for 11 p.m. and the audit trail shows that that nurse was documenting assessments or saving documentation for assessments at 11:05. Now, we could probably make an assumption or strong inference that what she charted at 11:05 were those 11 o'clock assessments. And most of the time that is going to be the case. But if you want to know for sure and you don't want to make any assumptions, there is hard data in the EMR system that you can request to prove what was the content of what she modified at 11:05. Was it only the 11 o'clock assessments? Did she change something else? Did she delete something? So the best step is to request additional data from the EMR system. So what I'm going to do is the next section is going to show you what my findings were, what the analysis was first and then the findings. But what I'm going to do, just to make it easier to follow, is I'm going to break it down into two sections. Part 1 is going to be what did the audit trail show, and without getting additional information, what could I tell just from the first audit trail? And then part 2 is going to be what I found out when I requested additional data from the EMR system. So some questions I did have enough information to answer, and that'll be in part 1. And then part 2 will be the information that I was able to put together after requesting more data from the EMR system. Hopefully that makes sense. Okay, here we go.
Part 1, Audit Trail Analysis. Question 1. The audit trail revealed the neuro-hospitalist saved drafts of the history and physical note on the evening of day 1, after the MRI resulted shortly after 8 p.m. The audit trail also revealed that the neuro-hospitalist viewed the MRI report soon after it was signed, and shortly before saving a draft of the note at 8:37 p.m. before leaving for the night. The neuro-hospitalist did not complete the history and physical note that night. The next morning, the note was saved as a draft a few more times in the hour before it was ultimately signed. Although the audit trail revealed the existence of several draft versions of the history and physical note, it did not provide a revision history. That is, it does not show when the words "stat-CT for any worsening or decline" were added. Therefore, that would have to be requested separately. The audit trail revealed the nurse practitioner reviewed the draft version of the history and physical note last saved at 8:37 p.m. around 1 a.m. However, when the nurse practitioner returned for the second overnight shift, he did not review the completed history and physical note at the start of his shift, nor did he review it before ordering Dilaudid. The audit trail revealed that the bedside nurse did not review any provider note for the patient, who was new to her, until after the code event, although she did review orders, medications, and nursing assessments. The neuro-hospitalist testified he created his acute stroke assessment documentation at 1:30 p.m. on day 1, roughly in the first hour of seeing the patient. However, the audit trail revealed he completed the acute stroke assessment documentation at the end of his shift, closer to 8 p.m. In his Day 2 progress note, the neuro-hospitalist discussed the patient's risk for cerebellar edema in 3 separate sections: assessment/plan, disposition, and communication. However, this note was first created at 3:22 a.m. and signed at 3:27 a.m., more than 2 hours after the patient's code blue event and more than 5 hours after the nurse practitioner entered the order for Dilaudid. On the face of the record, the service date and time was Day 2, 4 p.m. The neuro-hospitalist testified he created it at that time and only signed it at 3:27 a.m. However, he was not in the patient's chart at all between 12 p.m. on Day 2 and 2:30 a.m. on Day 3. According to the audit trail, the physician's testimony cannot be accurate. Question 2. Recall the nurse practitioner testified he viewed all notes, all nursing assessments, all lab results, and all medications before entering the order for Dilaudid. The audit trail revealed he accessed the patient's chart from a device on a different floor and reviewed the chart for 51 seconds before signing the order. He viewed the medications tab for 1 second and one care plan document for 1 second. He did not view the attending neurologist's completed hand P note. The majority of the 51 seconds were spent on the problems/diagnosis tab and the orders tab before signing the order. Therefore, the nurse practitioner's testimony was inconsistent with the objective data. Question 3. Recall that the medical records show neurologic assessments at 6:30 p.m., 7 p.m., and 11 p.m. The records also indicated the patient was sleeping at 11 p.m., and a neurologic exam cannot be performed on a sleeping patient. The medical records also show additional assessments timed for midnight, indicating the patient was resting in bed with stable vitals. The audit trail revealed when the nurse created assessment documentation. It revealed modification activity at around 6:30 p.m., between 9 and 9:30 p.m., 11:04 p.m., and after 2 a.m., which was 1 hour after the code and after the patient had been taken to the ICU. Based on this data, the 7 p.m. neurologic assessments could not have been created at 7 p.m. That means they were created ahead of time around 6:30 p.m. or were created after 9 p.m. and backdated to 7 p.m. The 11 p.m. assessments appear to have been contemporaneously documented, but the audit trail does not show the content of entries. It only shows the act. The content will have to be requested separately to confirm the chart modifications at 11:04 p.m. were the 11 p.m. neurologic assessments. The nursing assessments timed for midnight indicating the patient had stable vitals and was resting in bed could not have been entered contemporaneously because the nurse had no documentation activity at that time. Therefore, those entries must have been created at some time after 2 a.m. Additional requests for more granular data is necessary to determine exactly when specific assessments were created. Question 4. This is a question that goes beyond the data in the audit trail. We will return to this topic in the next section. Part 2. Conclusions based on additional audit data requested and not contained in the patient's audit trail. With regard to the draft versions of the H and P note, The note's revision history was produced, showing what the note looked like each time it was saved as a draft. That data revealed that at the time the neuro-hospitalist saved a draft of his H&P note at 8:37 p.m. on day 1, there was only preliminary information in the note. Although the neuro-hospitalist viewed the MRI results with the finding of an acute or subacute ischemic infarct in the left cerebellar hemisphere, he left the note largely incomplete and finished it at 9 a.m. the following morning. The words "stat CT for any worsening/decline" were added at 8:49 a.m., 10 minutes before signing it. With regard to the nurse's assessments, additional audit data revealed the 7 p.m. neuro assessments were entered at 9:05 p.m. and backdated. The 6:30 p.m. neuro assessments were created at 9:14 p.m. and backdated. The 11 p.m. neuro assessments were created at 11:04 p.m. However, the nurse was consistently and actively charting in 2 other patients' charts between 10:55 p.m. and 11:03 p.m. before creating this documenting seconds later. A jury would have to decide if neuro assessments were performed or performed completely at that time when 1. The nurse was actively charting for 2 other patients, and 2. When the nurse also charted the patient was sleeping at 11 p.m. The nursing assessments timed for midnight indicating the patient had stable vitals and was resting in bed was actually created at 2:08 a.m. and backdated to midnight. Recall the patient's code blue event occurred shortly after 1 a.m. Additional audit data also revealed that the nurse was actively charting for and completing nursing assessments for a new admission. The neuro-hospitalist, nurse practitioner, and nurse all made statements at their depositions that contradicted the audit data that was recorded in real time.
After I finished my analysis, I put my final conclusions and I put together the timeline and I made it into a formal written report that was quite long. I think it was like 25 to 30 pages maybe. And that report was given to the other side. A few months after that, the case settled, and it settled before the defense filed their own expert disclosures. And I bring that up because had they filed their own defense expert disclosures, I would have summarized that and included their defense theories in this video. But that didn't happen. So that's why I summarized or briefly summarized what the providers said at their depositions, just to give a little bit about their side or what they said in defense of the allegations against them. If you like this video, if you want me to make more videos, please like, comment, let me know. But that's it for this video, and I hope you enjoyed it. This is What the Chart Won't Say, where we follow the data and let the facts speak for themselves. Bye.
If you want to learn how to analyze EMR audit trails yourself like it was done in this case, and how to draft supplemental production requests for additional audit data not contained in the patient's audit trail, you can purchase What the Chart Won't Say, Tips and Strategies from an Audit Trail Pro, available at whatthechatwon'tsay.com.